Good evening, everyone, and welcome to our first cancer conversation for 2022. My name is Sanchia Aranda. I'm a Professor of Health Services Research at the University of Melbourne and helping the Institute in coordinating these and moderating these sessions. Before I begin, I would like to acknowledge the traditional owners of the lands on which we are all meeting today, and for me, I am here on Eora Nation. I'd also like to acknowledge traditional custodians of the lands on which you are all living, learning and working from today. As we share our knowledge and learning, may we also pay respect to elders, both past and present, and to any Aboriginal people joining our meeting today, and to also acknowledge in this important topic the important disparities in cancer outcomes that are experienced by people who are of our First Nations community. Since our last cancer conversation in November, we've been busy behind the scenes really rethinking and getting your opinions about these particular seminars, hence our slightly changed time, moving a little later, and a shorter presentation slot of only 1 hour. And we hope that that will enable a brisk conversation and opportunities to perhaps follow up afterwards for some of these issues. Our program tonight will discuss the prevention, early diagnosis, treatment and care of people with hepatocellular carcinoma. And we're really looking at primary liver cancer today. And we will start with some brief introductions in a moment before we then go into a discussion panel session. But we do want your involvement, and in this new Zoom format, we would like you to submit your questions through the Q&A function on your screen, and that will be, I'll try and moderate those as far as I can get to. If you see a question that you like, you can try and kind of support that if you like. If you do need a certificate of attendance tonight for your professional development purposes, there is an email address in the chat function to send your request to. And following the webinar tonight, there'll be a short evaluation email to you, and it would really help us keep this program developing and becoming more and more attuned to your needs by helping you to do that. So I'd like to introduce our speakers and panel members. So we have tonight Dr. Eleonora Filetto, Professor Jacob George, Associate Professor Simone Strasser, Dr. Fred Leung and Kindness Bondeza. And they're all going to participate in the panel, but we have 3 speakers to begin with. So to begin, we have Dr. Filetto, who leads the gastrointestinal cancer policy and evaluation stream at the Daffodil Centre, which is a joint venture between the University of Sydney and Cancer Council New South Wales. And her work focuses on prevention and early detection of colorectal and liver cancer in Australia. And the really critical piece at the moment is that she's been working on plans for a liver cancer roadmap for Australia. So welcome, Eleonora, and we look forward to hearing your presentation.
Thank you very much, Sancha, and thank you very much for having me here today. I'd also like to acknowledge the traditional custodians of the land, and for me as well, that's the Gadigal people of the Eora Nation, and I'd like to pay my respects to elders past, present and emerging. So today I'd like to start off the session and just talk a little bit about liver cancer in general in Australia, and really setting the scene for why we should be paying attention to liver cancer. The best way to do that is to start with the basic statistics on liver cancer in Australia and how it stacks up against the other cancers. So liver cancer is the 12th most common cancer in all Australians. So it was estimated that in 2021, there were 2,832 new cases of liver cancer. The majority of these were in males, so just over 2,782 in females. When it comes to cancer mortality, liver cancer is Australia's 7th most common cause of cancer death. So again, estimated deaths in 2021 were 2,424 deaths from liver cancer. And again, the majority of these were in males. So it may seem from these numbers that perhaps it's not the most important cancer in Australia, but what makes it one of the most important cancers is when we look at the change over time. And on the left-hand side, what you'll see are the age standardized incidence and mortality rates in Australia from the early 1980s through to 2019. And what you'll see very clearly is that incidence and mortality are increasing. Now, this is one of the very few cancer types in Australia where this is the case, and it is projected to continue to increase. So this is why we should be paying attention to liver cancer. On the right-hand side, you can see the 5-year relative survival of liver cancer. And again, from the late 80s to the mid-2010s, you can see that there's been very little movement in survival. So we have a case of liver cancer incidence and mortality are increasing, but not much is happening to survival. So there are things, there is space for us to do more and do better. Just to take another look at the change over time, I just wanted to share with you some recent work that we've done at the Daffodil Centre. We looked at the period of 1996 to 2015, that period in the box there, and we said, okay, we'd like to understand what the average annual percentage change was in this time. So on average, each year, how much is incidence going up and how much is mortality going up? In this particular analysis, we looked at only people under the age of 75. And what we found was that incidence was going up 4.6% each year on average, and mortality was going up 2.9% each year. And that was quite remarkable in comparison to the other cancers in Australia, where this was not the case. They didn't see the same increase. And what we also did is looked at the number of cases we would have expected if the rates from 1995 were maintained. So if nothing changed from 1995 and everything stayed the same, what would we have expected in 2015? And what we found was that the number of liver cancer cases was 66.5% higher, and the number of liver cancer deaths was 35.8% higher compared to what we would have expected if everything had remained the same from 1995. So again, this is one of the only cancers that we saw an increase in both incidence and mortality in this way. So as I mentioned, there's a lot of work that can be done, and Sancha mentioned in the introduction that at the Daffodil Centre and in collaboration with Cancer Council Australia and funded by the Australian Government Department of Health, we're working on the roadmap for liver cancer control in Australia. So this particular project aims to establish a roadmap for action to reduce the burden of cancer in the Australian community. And this, our aim is to provide recommendations for priority actions over the next 5, 10 and 20 years, and develop clinical practice guidance to support healthcare professionals to deliver best practice in identified priority areas. And we're working on that at the moment, and the identified priority area is HCC surveillance. And one of our 2 co-chairs of the roadmap is Professor Jacob George, who will be speaking after me. So with that, I'd like to say thank you and pass back to Sancha. Thanks, Sancha.
Thanks, Eleonora. And clearly everybody can see that this is a problem we need to pay attention to. And I think one of the real challenges this is the disparities that exist and the population of people who get liver cancer in the main. So I'll hand over now to and introduce Professor Jacob George, who is the Robert W. Storr Professor of Hepatic Medicine at the Storr Liver Centre at Westmead Institute for Medical Research and the University of Sydney. And Jacob is also the head of the Department of Gastroenterology and Hepatology at Westmead Hospital and at Western Sydney Local Health District. And he is both a basic and a clinical researcher in the area of many of the liver cancer precursors. So Jacob, I'll hand over to you.
Thanks very much, Santia, and to the organisers for inviting me to talk today. Tia, can we just go to my single slide, the next one? Okay, so what I thought I would cover in the next 5 or so minutes is really looking at the early part of the cascade in terms of liver cancer. And I think many of you will not know that primary prevention is possible for at least 2/3 of liver cancer cases. So if we can undertake primary prevention, we can completely change the narrative that Eleonora was just talking about, the growing incidence and mortality and the burden for patients and for families. Today, we know that about 2/3 of liver cancer is either due to hepatitis B or hepatitis C. In the next couple of decades, there are going to be a couple of other diseases, particularly fatty liver disease, but currently it's hepatitis B and C. For both of these diseases, which represent about 70% of our cancer cases, we've got an easy blood test to tell you whether you've got hepatitis B or C, and we've got highly effective therapies. So for hepatitis C, with an 8 to 12-week course of treatment, we can cure hepatitis C. And for hepatitis B, with a similar tablet, we can control viral replication. If we can do that for B and C, we can either eliminate or reduce the risk of liver cancer development, in other words, primary prevention, anywhere between 60 and 90%. So it is possible to change the narrative. But how do we achieve that? We need to have a multi-pronged approach through our whole community. First and foremost is health promotion with the affected communities. So we need to be talking about viral hepatitis screening, going to general practitioners and having a test for hepatitis B or C. We need to educate the community about the risks for liver disease and cirrhosis from alcohol, and also from fatty liver disease. If we move from the community to primary care, there still is work to be done in terms of general practice education and to inform them of the message that hepatitis B and C today is a diagnosable, treatable, and potentially curable disease. The other part of the problem is that many of our patients who develop cancer, at least 90% of them have liver cirrhosis. Once you have cirrhosis, the treatment is not the treatment, I should say, but the way we diagnose cancers early is for surveillance. Now, we don't need surveillance to be done in tertiary centers and in hospitals. We can devolve all of this in primary care, as we have done in some of the practices in Western Sydney where I work. But we need to get general practitioners involved in regular surveillance of our liver cancer. What we want to see is not having to diagnose cancer when patients are symptomatic, when we can't do anything about them. We'd rather detect small, curable, 1 or 2 centimeter lumps in the liver if we have to diagnose them, so that we can treat them and potentially cure them. Involving peer support workers in linking patients to care is important, and this is particularly so for hepatitis C. Many of our patients with hepatitis B and C are marginalized, and to link them to care and to health providers, what we have found, and across the state we found, is that peer support workers provided by Hepatitis Australia or Hepatitis New South Wales has been very useful. Now, there aren't enough clinicians to do all the work in terms of primary prevention, and we've really made a big difference trying to use nurses and nurse-led clinics to empower patients and to empower general practitioners and primary care to lead the effort for primary prevention. And I think Kindness, who works at Westmead, will be talking a little bit about our nurse-led clinics. And so what can be done? These are a couple of projects that I've listed there. A B Positive program, which we did over a few years, back in the early, between 2007 and 2013 in Southwest Sydney. Similar program that we've got in Westmead, in Western Sydney, LHD, called Hotter West, and then a focus group, which is another community-based program. And all of these programs have at the core having the patient at the center, using nurse-led clinics, increase awareness in the relevant community, whether it's patients with hepatitis B or hepatitis C, linking them to general practice and to general practice surveillance, linking them to treatments, in other words, drug treatments if they require it, and then if they've been cured and they have cirrhosis, then linking them to care. So I think primary prevention is possible, and we must spend a lot of attention trying to improve our primary prevention for liver cancer. The other part about liver cancer is we're very much with liver cancer where breast cancer or prostate cancer was 30 years ago. Bad survival rates where a diagnosis essentially meant a death sentence. And this is really because we haven't had sufficient basic or translational research into liver cancer. By basic research, I mean, why does liver cancer develop? Why do they respond poorly to treatment? And how do we find new approaches to drug treatment? So basic research should be undertaken, and also translational research. So if you look at all that bit I've said about primary prevention, the missing piece in the puzzle is implementation. So we know what to do. We know how to identify patients with a blood test, but we're not putting the two pieces together to undertake translational research, implementation research, to make sure how best we can find the patients and link them to care. So I guess that's my wish list for prevention of liver cancer. Thank you.
Okay, thank you so much, Jacob. To a technical difficulty at my end. Really important issues, and we're going to hand over now to Associate Professor Simone Strasser, who has the responsibility of actually seeing these patients after all of the things that Jacob's talking about really haven't gone as well, or maybe go well with early diagnosis. Associate Professor Strasser is a Senior Staff Specialist in the A.W. Morrow Gastroenterology and Liver Centre and the Australian National Liver Transplant Unit at the Royal Prince Alfred Hospital and the University of Sydney, and she's also Director of Hepatology Clinical Trials at RPA and is leading trials of new therapies for patients with liver disease and liver cancer. So welcome, Simone. Thank you.
Thank you so much, Sancha. And yes, now I get to sort of share about how do we actually diagnose and manage HCC in the current era, because at the moment we haven't had a significant impact on reducing the diagnosis rate. As you've seen, it's going up over time. So we are implementing surveillance, which doesn't diagnose, it just indicates that there may be a lesion that may be HCC. So I would like you to be aware of the Australian recommendations for the management of hepatocellular carcinoma, and this was a consensus statement with multiple stakeholders, as you can see represented around the border of this figure. And there was a summary version that was published in the Medical Journal of Australia middle of last year. And the full version, which is quite an extensive document with a lot of referencing, is available on the website of the Gastroenterological Society of Australia. And this is a living document that we hope to update as new information comes to hand, and particularly new therapies. So these are some of the figures, and I've just brought two figures out of that document, really to highlight a few issues that I think are really important. One is that we are indicating for patients to undergo surveillance when they've got cirrhosis. And that does mean in primary care, we've got to find those patients with cirrhosis. And there are various ways and strategies that we can increase the cirrhosis detection rate in primary care. But once somebody's got cirrhosis, they should all be in a surveillance program for HCC with 6 monthly liver ultrasounds, with or without a serum AFP. The ultrasound's a critical step. The AFP is an add-on test. We also recommend surveillance for patients who are at risk who have chronic hepatitis B in particular. But most of the patients, as was mentioned earlier, have actually got cirrhosis. So we do ultrasounds, we do them every 6 months, make sure that the patients are actually getting those ultrasounds, and it can certainly be done in primary care. It doesn't have to be in specialist centres. And then what do we do when we find a lesion? Well, if it's under 10 millimetres, often the radiology report will say suggest MRI, suggest CT scan. It's really not necessarily in a tiny several millimetre lesion to do that. And the guidelines suggest we wait until it's 10 millimetres. So we repeat the scan in 3 months. If it's 10 millimetres or more, then they have a multi-phase CT or an MRI scan. And that means that we're giving contrast to the patient, and we're seeing what this lesion does as the contrast goes in, which is the arterial phase of the scan. And then we wait another minute and we see what the lesion looks like a minute later. And then we look again on a delayed phase 5 minutes later. And HCC has a very characteristic pattern because it's supplied by branches of the hepatic artery, whereas the rest of the liver is supplied by the portal vein. So HCCs will turn bright on the arterial phase and then wash out on the portal phase and the delayed phase. And if we see that in somebody who's at risk for HCC, then that's HCC. We make a diagnosis based on imaging, and we would not really need to biopsy that lesion to confirm it. However, if the characteristics on that imaging are not classical, we might follow up with another imaging modality such as MRI, but still not classical, then we might recommend a biopsy for that. What's really important is that all these patients are managed within an MDT or multidisciplinary team. And that means that patients who are clearly got benign disease can be sent out of this pathway and just continue with their normal HCC surveillance. Those with a definite HCC, based on their imaging criteria, then go down a treatment pathway. And those that are indeterminate need further evaluation with, for instance, a biopsy, as I mentioned. So an MDT is critical, and all patients should be referred to an MDT for evaluation of their diagnostic imaging and to be delivered treatment. And the MDTs that we all run, and these are through all the major liver centres and particularly in Sydney, but also in many of the regions. And if the regions regional centres don't have an MDT, they'll refer down to the main MDT, such as at Royal Prince Alfred or at Westmead. The patient's at the centre of the management, but all these clinicians are also involved in an MDT process because there are so many different ways that we can apply therapy to improve the outcomes of these patients. And what we do within the MDT is, firstly, we confirm that this is a diagnosis of HCC, and then we stage it. And we use the staging system used from the Barcelona Clinic Liver Cancer Program from Spain. And this has been adopted in Australia as well. And this is an incredibly helpful format for staging the patients with HCC based on their imaging and based on the status of their liver disease, because outcomes in HCC are not just due to the cancer itself, though a bit different from other cancers, it's also due to how advanced the liver disease is in that person. And as we said, most of them have got underlying cirrhosis. So we look at their child's Pew score, whether it's A, B, or C. We look at their performance status. So 0 means really, healthy, well, no symptoms at all, right through to greater than ECOG status of 2. So 3, 4 is really patients who are spending most of their time in bed or are hospitalized. So these therapies that we're talking about are really limited to those with a good performance status and a relatively preserved liver function. And then we look at the size of the liver lesions, how many liver lesions there are, and particularly whether there's vascular invasion or metastatic spread, which would put these patients into a BCLCC class. And then we've got lots of therapy. So again, the beauty of having an MDT where all those clinicians are represented is that we can apply the best treatment possible to the patient who's now been diagnosed with HCC. And the curative options are ablating it, so putting a needle in, delivering microwaves usually down that needle and basically cooking the lesion and destroying it completely. And on follow-up imaging, you should just see a defect there with no ongoing cancer. Some patients will be resectable, and so surgeons are represented at the MDT to give that opinion. Some patients are good transplant candidates which is really the definitive therapy to take away the whole background liver and replace it with a healthy liver. If none of those are appropriate, then we'll do chemoembolization, where we put a catheter through the femoral artery in the groin and deliver chemotherapy just into the tumors themselves and trying not to damage any of the surrounding liver. And then as patients progress through this, or if they present already with advanced disease because they haven't been in screening, then that's where systemic therapies are. And really, we were very nihilistic about, and there were really no systemic therapies up to about 12 years ago. And what we have now is a range of systemic therapies that have really had a significant benefit on survival. So we're really very optimistic, regardless of the stage of disease of patients with HCC, except when they're really in this terminal stage where they've got very advanced liver disease and really extensive cancer. But systemic therapies have come an awful long way. We've had oral multikinase inhibitors available since 2008, 2009. And we've had several of those, and they're still available in first-line therapy. But since about 15 months ago, we've had access now to immunotherapy. And that's really improved the survival significantly. So without therapy, patients in this advanced stage would have a median survival of, say, 8 months. With the current immunotherapies we're using, we're up to over 19, 20 months of median survival, and many patients are really surviving for 2-3 years or more on therapy, even when they've got quite advanced disease. And these therapies are very well tolerated, they're PBS funded, and we've got more and more therapies that are under clinical trial development at the moment that we hope to bring to the clinical situation. So there is, even when patients have got been diagnosed with HCC, there are a lot of therapies. We can certainly cure some people, but we can also prolong survival in the vast majority of the others. So thank you, and I will stop sharing there and hand back to Sancha.
Thanks so much, Simone. And if I could get all of our panelists to turn on their videos now, I'd like to welcome Dr. Fred Leung, who is a general practitioner at the Auburn Healthcare Centre with experience in multiple areas of health, including in the management of liver cancer patients, and also welcome Kindness, who is the Hepatology clinical nurse consultant at the Store Liver Centre at Westmead, and is leading a team that's focused on testing, treating and managing the healthcare needs of people living with viral hepatitis, advanced liver disease, metabolic associated fatty liver disease, and hepatocellular carcinoma. And so I'm going to start our panel discussion with some questions to our new panelists. So Fred, for you as a working GP with a predominantly Chinese population, you've developed an amazing working relationship with Professor George and the team at Westmead. And I wondered if you could tell us a little bit about what this change management structure looks like for people in your clinic with high risk, who are at higher risk, particularly hepatitis B patients, and what a difference it's made. What have you seen change through this more collaborative approach working with the acute health environment?
Yeah, what happened is I in my clinic, I have 90% of them is Chinese. For that 90% of Chinese patients, nearly 5 to 10% of them is a happy carrier. Now, when the patient come to my surgery, we will do some screening for the adult. We do a screening test. If once I confirm they are chronic happy carrier, so then I will make a referral for them to enroll them into the liver clinic. Now, I will keep on monitor those patients and do a regular checkup. If they have abnormally high ALT, happy DNA, or high AFP, then I will basically send an email to the liver clinic, to the Professor George teams. So I'm quite happy that actually the team is very supportive. Within 24 hours to maximum 48 hours, I get response from them to give me some sort of direction, how to manage the patient. If the patient, basically, if they are normal, all this reading is normal, I will keep on monitoring those patients on a regular basis, just like every 6 monthly, keep on checking the patients. So essentially, I find that you're working very well. I think we are feel being supported by the team, so we are quite comfortable to working in that collaborative manner. So in terms of the difference, I find there's a huge difference. Whereas in the old day, the patient mainly seen in the liver clinic, they easily wait for 2-3 months before they can be seen by the specialist in the liver clinic. But now what happened is, because we do all this basic work, doing the screening for the patients. So only the liver clinic seeing some patients, they are particularly have problems like high ALT or high happy DNA. Otherwise, all this easy, straightforward patient will look after by my clinic. So, and I easily get advice if in case there's some problem with those patients, I usually get advice from Professor Josh's team. So, and I find that the difference is, first of all, we are much more accessible, and the patient easily, we have 4 GP actually have the prescribing right. So we can start treating the patient with the guidance from the liver clinic. And I find that in terms of the compliance of the patient, because we know the patient, we know the family, so we keep on, monitoring the blood, and sometimes they come in for other issue like sore throat or coughing. So we always remind them, are you taking your medication? Are you having your regular blood check? So we working closely with the patient, and the patient fully understand the logic, why they need to be on medication. So in terms of the compliance for the regular check of the medication, and I find that they are working much better with their GP rather than their liver clinic. So I find that it's quite successful in terms of minimize the possible complication or liver cancer. And since that we working in that way, I find that the patient having the advanced stage liver cancer much reduced. So I'm quite happy with this type of arrangement. It's quite a big success, I feel that.
Thanks, Fred. Kindness, I'll move to you now. You work with high risk and vulnerable patients, and this is a group who have many challenges in terms of ability to navigate our health system, health literacy, language. In what ways does your specialist nursing clinic help the patients to kind of stay on track and improve their outcomes? And what are the particular challenges that you and your team face, and how you overcome them? Because it's quite a new role and quite unique, really, isn't it?
Thank you, Sanchia. So we at Westmead have a couple of nurse-led clinics that we do both in the outpatient and in the community setting. But I guess our biggest one would be the outreach clinics, where we have a mobile van that we take to the high-risk and vulnerable populations and test predominantly for viral hepatitis. When we take the van out to the community, we're providing this service to patients that would otherwise not turn up to the hospital for whatever reasons. So we're going to homeless shelters, we're going to places where homeless people are fed, we're going to women and youth refuge shelters and taking the van there. So we take the van frequently, and so a lot of the clients become well-versed with the van, they become comfortable with the van. We provide a friendly and safe environment for them, so they trust the service. On the van itself, we have highly specialized nurses. We take with us a pathology collector who's highly experienced, who helps us with the blood collection, because it is a big factor. If we miss the veins, then the word goes around. Luckily, we haven't had any incidents like that. I guess with the viral hepatitis screening, the aim is to find these patients, treat them, make the treatment pathway easier for them, treat them in the community. And also another aspect that the van does do as well on the side is the GP linkages with services like Dr. Fred Lung, provide education to both the GP practices and to the patients. Lots of challenges that we do come across. One would be obviously the type of patients that we are going out and seeking, low health literacy. So a lot of education. We bring with us peer workers as well, speak to the patients at a level that they understand. We also have the issue of, I guess COVID has really been a major challenge. We can't bypass that one and not speak about it, whereby we haven't been able to take our van to places that would normally go because of social distancing, because of all the rules that are surrounding it. So that has just made our work a little bit harder, but I guess we are getting back on track and we're trying to overcome all these challenges.
Fantastic. Thanks, Kindness. It's really exciting to see these kinds of roles developing, and the kind of, I think, culture shift that your role and Fred's role are taking within communities to really change the sense of acceptance of these kinds of services. And I guess you could argue that the approach that's been developing between Westmead and Auburn Medical Centre is really best practice. I'm interested in our panelists' views about whether that can be the norm in the health system, because it's riding on the backs, I think, of a lot of energy of individuals. And I think it's appropriate that we should mention the work of the late Professor Monica Roberton here as well, who was instrumental with Jacob in really getting the Be Positive program off the ground. But if it is to be the norm, what is it that we need to make this happen and for the case to be created to our health funders? Anybody want to take that on for me?
Look, I mean, I think the difficulty from my perspective is that tertiary hospitals and the way the health system is funded is mainly focusing on acute care. But preventive care in the long term is much more cost effective. You have to do it in the community. And, you know, I'd find it very difficult to keep abreast and be like a GP because they need to know everything about everything. It's impossible. It's easier to know something small about liver than everything that they have to. But to recognize that if we can bring some of the specialist expertise and to partner with the GPs, working with their community, in their community, that actually saves a lot of money long term. So it does require a culture shift and thinking differently. And it is slow, but I think it can be achieved.
And it feels like it's a very effective then way to have roles like Kindness's team creating that bridge, because, you know, you couldn't spend all of a hepatologist's time doing that linking. So that becomes really important, I'm imagining. Simone, what difference has it made in your practice to see some of these patients earlier at your NGTs than because they've come through a surveillance program?
Oh, we absolutely know. We've got data from our unit and from Jacob's unit that the patients who are diagnosed within surveillance have a significantly improved survival than the patients who walk through the door with a big symptomatic cancer, where the median survival may be 6 to 8 months. So we've got patients where we've been treating for little cancers, you know, that have arisen years ago. They're still alive. They occasionally still pop up a new cancer. We treat it again. And they can be like that for many, many years, or they can come to transplant and not get any more cancer after that. So it really provides that opportunity to provide curative therapy. And even when we can't cure a cancer, if it's early stage, we can still treat it effectively to prolong survival. And even if we do get to the point where they get to systemic therapy somewhere down the track, we're still prolonging survival. So we don't, you know, there was sort of this framework, well, either people get curative therapy or they're palliative. And I think that's not the right framework in this cancer. I think we should be talking about certainly curative. So if we can try and cure that cancer that's there and be watching for the next one, because these patients are still at risk. But even for the ones where we can't cure it, we can still extend life significantly and improve quality of life and maintain quality of life. So it's a different framework around this.
Fantastic. Eleanor, I'm going to come to you next, and I'm going to take a question, one of the audience questions, but also add it in. So you mentioned that surveillance is part of the recommendation. So I think what my question would be, because when I first looked at it a while ago, the evidence around surveillance, or the methods for surveillance was really just emerging. So I'm interested in where your roadmap has landed on the evidence for that. And then there's Christelle Manuel has asked, is there a future for liver screening tests to become part of the population-based screening programs? And is that something that might actually be featured in something like a roadmap?
Great, thanks, Sancha. That's a lot. So please pull me up if I don't cover it all. And I just want to acknowledge that Jacob and Simone are both involved in the roadmap process that we're going through. So please feel free to contribute as well. I guess one of the starting points from the roadmap was really to engage with an expert advisory group and say, okay, what are the priority areas? And they, as this group has also highlighted, suggested that screening for advanced liver disease and HCC surveillance in high-risk patients were priority areas, and asked us to look at the evidence. And what we found at the time was that whilst screening for advanced liver disease exists, the evidence isn't as robust as an area such as HCC surveillance in high-risk patients. So what that means is that probably at this point, given the evidence that we have, incorporating a test into the population screening framework, which requires looking at the benefits, the harms and the costs, and assessing that for the whole of population probably isn't, we're not ready for that, where HCC surveillance has been identified as something that's really quite important at people who are at that higher risk already, so not the general population. And we're talking about specific migrant groups, we're talking about people with cirrhosis, as we've mentioned. So there are very clear groups where those can make a difference, and there is good evidence to suggest that will help improve outcomes.
And hopefully the pilot around the National Lung Screening Program might set the way for how we do high-risk screening into the future in more high-risk groups.
Correct. And I do, sorry, Sandra, I do want to acknowledge that there still is research going on in that advanced liver disease space. So it's not that that's a closed door and we would never come back to it, but that's something that we need to put some more active energy into. And I have to say that people are doing that with a lot of enthusiasm. So we're very much looking forward to seeing the outcomes of those research projects.
Yeah, fantastic. And kind of just following on from that, what do you see as the challenges to participating in surveillance that you see with some of these high-risk populations? Do you have to kind of do a lot of chasing? Is it the systems that Fred puts in place in his clinic? You know, what are the sorts of mechanisms that exist when it's not a population screening program where people are invited, but rather it really does require energy from people like you and Fred?
Yep. So I guess the biggest challenge is the patient compliance, where patients will not participate in the surveillance program. And that's where, when you've got a good engagement with the GP practice and you provide that linkage between the nurse, the GP, the specialist, and the patients are aware that they've got access to this specialist if required at an earlier rate than going through the liver clinic referral system, then it produces a lot of compliance from the patients as well.
Right. And Simone, the changing demographic and epidemiological picture will influence this too, right?
Yeah, well, the epidemiology is really changing quite rapidly. We've had treatment for hepatitis C since 2016, funded on the PBS, and hepatitis C associated liver cancers are decreasing significantly. Mm-hmm. And we are getting more patients onto antiviral therapy for hepatitis B through all the efforts that you've heard about. And so hepatitis B related, particularly advanced cancers, is going down. But the growth areas, so to speak, are with fatty liver disease due to metabolic risk factors such as obesity and diabetes and alcohol. And that's where we're really seeing an explosion almost of cancers. And many of the new patients with cancer that we're seeing now, it's on the basis of fatty liver disease or alcohol-related liver disease. And that's changing the epidemiology significantly. And the sort of patients that particularly are being seen in primary care, it's now switching to people with long-standing obesity, diabetes, with or without alcohol, where it's harder to identify the risk for HCC. It's harder to find the patients who have got cirrhosis, for instance. And some of those patients, in fact, don't have cirrhosis at the time that they develop liver cancer, and therefore are presenting more advanced as well. So this is really becoming challenging. And the first step is really going to be around identifying in patients at risk of liver disease, who are the patients with more advanced liver disease who are thereby going to be the ones at risk of cancer. So it's a whole new area of education and upskilling, particularly in primary care and community.
And maybe Jacob and Fred, are there differences in the way that you work together on surveillance according to those different epidemiological pictures? Have you got different strategies?
Look, I think, as Kindness mentioned, from my perspective, the best engagement you're going to have with a patient is with the primary care physician. So if you can devolve surveillance from specialist care to the GP, that's the best way you can ensure that the patients who require it are getting screening. So it's all about education and health literacy, and equally telling the general practitioner that if you can do this, you're actually doing a lot of benefit for your own patients. And most, virtually all GPs get it. But there is this work that needs to be, works in Fred's case, because, he's got a large practice and there's a practice nurse, and we can harangue the practice nurse as opposed to haranguing Fred if a patient doesn't have their screening tests. But look, every year he sends us 2 or 3 cancers that are picked up through screening. And while I don't like to see those cancers, that they've developed cancers, it's refreshing to see that we get them as small cancers. Then we can do all those things that Simone said, and we can potentially cure or at least give them relatively long survival.
Fantastic. Fred, anything you want to add?
Yeah, I think 2 things I want to mention. One is actually the patient compliance, because for the hepatitis, unless just in the late stage, the patient have all these symptoms of liver failure, by then that will be too late. And otherwise, a lot of patients do not realize how risky they are. They not commonly not go to see the GP doing routine screening. Despite that, we told them, look, you need to come back, no matter how good is your blood or ultrasound, but you need to come back every 6 months. But some patients, they are not listening. So until that they have some symptoms, unfortunately. So I think that's very important in a GP's level. Have a good relationship with the patient and speak their language. So explain to them, make sure they understand. That's very important. They need to keep on coming back for a routine screening. That's number 1. And other thing is, I find that in terms of the GP, they are not really keen to involve into managing their patients. So I believe that more GP have to understand early diagnosis of those liver cancer or cirrhosis is very important. So that's important as a GP, do routine screening rather than put all this responsibility to the liver clinic. Whereas the specialists in the liver clinic, they do not have time doing all those screening and look after these do not have complication patients. So I hope that they concentrate on mainly a complicated patient, and then we do all the screening work. So I believe that we can use our resources more effectively.
Thanks, Fred. Now, before I move to some questions about treatment that Simone might like to look at before I ask them, Eleonora, can you give us anything on the statistics on liver cancer and risk factors in the Aboriginal population?
Thanks, Sancha. I have just been double checking the figures because I did see that question come up. It's the beauty of being at home in front of your computer. And so I've looked at the incidence rates from 2009 to 2013, and in the Indigenous population, they were 15.5 per 100,000, and in the non-Indigenous population, it was 6.4. So there's quite a difference from an incidence perspective, and from a mortality perspective, it was 15.3 in the Indigenous population compared to 6.3. So we're seeing quite a high prevalence in both incidence and mortality.
Terrific, thanks, Eleonora. So Simone, What is the future of liver cancer treatments? You've got a few questions. Is it going to be all about immune checkpoint inhibitors, or are there other directions being taken, and what are the sorts of drugs that are currently being used to treat liver cancer successfully, I guess, rather than unsuccessful treatment?
I could talk about that topic for hours.
I know. That's why I've left it till close to the end.
So what do we have currently? So at the moment, the state-of-art treatment that we have on the PBS is immunotherapy, which is a drug called atezolizumab, and it's given with an anti-VEGF or vascular endothelial growth factor agent called bevacizumab. And they work together to affect the blood vessels that are making the tumor grow, and also the immune environment, and breaking down those checkpoints. And we know about how those treatments work from many other cancers where these treatments have been available for now over a decade. But in HCC, this has only been available in Australia since the end of 2020. So fairly recent. And they're easily given. They're all infusional. They're given every 3 weeks in a cancer centre. So that's got a whole lot of resource implications and impacts on where the patients actually live and how they can access those centres. But they're very well tolerated. We see very few toxicities related to them, and they can keep going while they're responding to those therapies. We also have oral therapies, tyrosine kinase inhibitors such as lenvatinib and previously sorafenib, and we still use those in some patients. And where we're going, there are clinical trials combining the two. So I've got clinical trials combining, for instance, lenvatinib with an immune checkpoint inhibitor, such as pembrolizumab. We're waiting for data in that, and that may provide the better response than we're seeing now. We don't know. We've got to see the data. And we're also seeing these immune checkpoint inhibitors being applied in combination as well, which is, it may change the scene as well. So where we're going to get to is we're going to have multiple therapies that are available, hopefully, and we'll be able to personalize the approach, even in advanced cancer, to the sort of disease that the patient's got, their extent of disease, and also possibly the underlying cause of the cancer, because there's some data emerging that the immune checkpoint inhibitors may work differently in fatty liver disease to how they work in viral hepatitis, and maybe there are advantages in some patients to going straight to oral kinase inhibitors. So it will be a much more personalized approach. And the other thing is we're seeing is that these therapies are coming earlier in the paradigm. So we've got clinical trials underway looking at them as adjuvant therapies in patients who have had a resection to stop that next cancer coming or stopping recurrence. And we've also seen them adjuvant with TACE therapies. So we're seeing them much earlier in the treatment paradigm as they're well-tolerated therapies. So it is evolving very quickly. We're very excited about this. In Australia, most therapies for liver cancer are delivered by hepatologists, with oncologists supporting that care as well. Varies, but we're really seeing good outcomes, and we're really changing the paradigm.
So there was also a question around, is there a role for the old traditional anti-neoplastic sort of cytotoxics, or it's really, I mean, I remember as a nurse in chemotherapy day unit, you'd give it, but didn't make much difference. I'm assuming not much role, right? So
there's really no role in the Australian setting. There are some centres elsewhere that may, but there's no data to support standard chemotherapy approaches. We do use, for instance, doxorubicin as part of our TACE, but that's targeted within the tumour itself. It's not systemic therapy.
Yeah.
I think the problem with, the conventional chemotherapy is that, it's a blunderbuss approach to kill everything. And our problem in cirrhotic patients is that they've got very little functional reserve. And so if you use conventional therapy, not only do you kill the tumor, but you kill the small amount of liver they've got left to survive, which is the problem. So really the approach has to be, as Simone was talking about, mixing and matching, but essentially targeted therapy that would just pick off the cancer cell.
The other therapy I didn't mention that's really gaining traction is stereotactic radiotherapy. Previously, when we've tried to give radiotherapy to the liver, it's been very poorly tolerated. But now with new modern radiotherapy machines, you can really hone those X-ray beams right onto the tumour, and you can treat quite small tumour very, very selectively without damaging surrounding liver. So now we're using more and more of that form of therapy to treat even small lesions particularly when they're not amenable to other loco-regional approaches such as the chemoembolization I mentioned or the microwave ablation. So we're bringing that earlier into the paradigm as well, not just regarding it as a palliative treatment. We're really going for ablative radiation now, targeting small tumours. So it's all, yeah.
Jacob, there was a question about the role of a Fibrous Scan in surveillance.
Yeah, look, I mean, the use of a Fibrous Scan predominantly is to stage the extent of liver fibrosis. As we all were mentioning, cirrhosis or very advanced liver disease is the precursor soil on which 90% of liver cancers occur. The problem with Fibrous Scan is it's not funded through Medicare. Many hospitals do have it, and some of the newer ultrasound machines have a Fibrous Scan capability. And if it's used correctly, it can narrow down the group that we have to surveil. The hepatitis B and C, it's relatively easy. You've got a nice diagnostic test. If you look at the fatty liver population or the alcohol population, the much larger population, you want to try and pick the ones with the advanced fibrosis. And so for those groups, if you've got access to a Fibrous Scan through your local radiology practice or through the clinic, a liver clinic, then that can be very, very useful. Decide who to screen and who not to screen.
Yeah, and so they are quite important developments. Fred, one of the questions that somebody who may have missed the beginning has asked is around why liver cancer or risk factors are higher in some populations. And I was interested the other day when we were chatting about this around, you've got a big practice with the Chinese population. You talked about the changing epidemiology even in that population between older and younger. So maybe you might like to talk a little bit about the risk factors in your population and whether or not it's stigma that discourages testing or whether it's just kind of acceptance. And
yeah, I think what happened is back 30-something years ago, in China, the health system still not quite good. At that time, they reused the needle. They sterilized the needle by just boiling the needles and reuse it. And sometimes maybe even use the same needle, giving the baby injection, multiple injection with the same needles. So I believe that may be one of the major cause of spreading a huge number of population in Chinese community, particularly, that's where before there's a vaccination available. And they have no screening whatsoever at that time. So that's why they're making a huge number of the Chinese people, they migrate from China to Australia. If they are 30 years or above, and they definitely is the group that I need to focus on, make sure they are not a heavy carrier. Otherwise that, those patients are high risk essentially. So, but for those people, they are younger than 30 years old, but I find that they are quite good. Most of them already vaccinated in China, and the incidence much reduced for that group.
Yeah, so that will be that we'll see that shift from Hep B predominating to fatty liver disease predominating. So I'm going to ask each of you just to wrap up with a 30-second soundbite about what you think we need to do as a health community to kind of address this problem that we're not currently doing now. So where would you put your priorities? So I'll start with you, Eleonora.
I'm going to go really basic and say we really need to improve awareness because just not enough people know that this is on its way and it's going to be a huge problem if we don't get on top of it now.
Kindness?
So I'll speak on behalf of all the nurses, increase the nurse-led clinics, increase more funding for nurses. We want more vans out. Every district should have a couple of vans. Let's go out and find the patients and treat them where they are.
Fantastic. Fred?
Now, I think we'd like to encourage all the GP, if they have happy patients, I think join me to working together with their local hospital, liver clinic, and provide the bespoke care for their patients.
Fantastic. Simone?
I'll come at it from a treatment angle because I agree with all the comments that have been made, obviously, but really to develop personalized approaches, because not all of these cancers are the same in every patient, and we need to understand those factors so that we and develop cancer treatments that we can apply across the stages and according to the sort of cancer that a person happens to develop.
Terrific. And Jacob?
Look, I agree with all the comments, and I guess my take-home message really, and my hope is that if a person is unlucky enough to develop liver cancer, we can pick it up through surveillance when it's early and it's curable and it has no health impact on them or their families.
Fantastic. So I encourage you all to make sure that you send the recording of this out to your friends and families, to very much thank our speakers and panelists tonight. It's been a revelation in such a critical area that I think epitomizes how we start to join up the prevention, early detection and treatment aspects of the cancer system, which are in dire need of some connecting in cancers like liver cancer, and hope to see you all again at the next cancer conversation. And please let Tia know if you'd like a certificate of attendance. So thank you all very much for attending tonight.
Okay. Thanks, Sanchia. Thanks everyone.
Sandra. Thank
Bye.
you.
Bye.
Bye.